Hi, everybody. Thank you so much for coming here today and for attending this session. I recognize this is the last session of the last day of a very busy week, except for the closing ceremony, of course. So I'm even extra appreciative that you're all here. My name is Jennifer Daves, and I just retired from the Bill and Melinda Gates Foundation. I was there for 13 years, so I'm just here having kind of a last hurrah, so in moderating this panel. And today we will have 3 speakers, and I'll introduce each one before their presentation. But I wanted to let you know we have one speaker, our second esteemed speaker, who will be speaking in French. And if you have, I don't know if you've done this before on any of your other sessions. I actually haven't, so I just learned how to do it. But you scan that, and then you would choose English, and then you'll be able to listen on your phone to her presentation being translated from English to French if you need that. And then obviously the opposite is true as well. If you'd like to hear the other presentations in French, this works this way as well. So hopefully that will run smoothly. The other thing I wanted to note is that our 4th speaker who's listed in the program, who's from Action Health Incorporated in Nigeria, unfortunately is not able to be with us today. I'm disappointed personally because I, love Nigeria and was so interested in hearing what she was going to speak about, which was displaced adolescent girls in Borno State. However, all of the abstracts and papers will be on the website. So if you'd like to learn more, everything will be loaded onto the ICFP 22 website eventually. So those are my 2 notes. And this session topic, as you probably know, is barriers to access contraceptive methods among adolescents and youth. And as all of you are probably familiar with this field, we know there are many barriers that face women who are interested in seeking family planning services. And for those of you that work with adolescents, we also know that there are even additional barriers facing adolescents. So our speakers today are going to be sharing their experiences and learnings and recommendations to reach this vulnerable population, which does need additional techniques to reach them because they are a vulnerable high-risk group. So our first 2 speakers will speak from examples of 2 different perspectives. The first is a country example from Nepal, and then the second is reaching high-risk youth in Burkina Faso. And then our 3rd speaker will broaden the topic to a more global perspective. So I think it'll be a very interesting combination of speakers. And again, we're glad you're with us. So getting started with our first speaker, I'd like to introduce Kavita Arial. Hopefully I did the name right, or close. She is the Family Planning and Reproductive Health Section Chief of the Family Welfare Division of the Government of Nepal. And please join at the podium. We'll have her speak for 15 minutes. We'd love to do questions at the end, so we'll hear all the presentations and then questions. So thank you again.
Thank you, and hello everyone. Good afternoon, and welcome to my presentations. I'm Kavita Arial, and from Ministry of Health and Population, Nepal. On behalf of my study team, today I'm going to present the functional analysis of ongoing adolescent-friendly services in Nepal. And okay, I'd like to share some background of Nepal. Nepal is the home to 2.9 million peoples, and among them, 25%, around 24.919% peoples are adolescents, and we know that adolescents are the period of transition from childhood to adulthood. And if we talk about the adolescent profile in Nepal, adolescence sexual reproductive is one of the major issues in Nepal, as child marriage is high there, early childbearing is also high, and the knowledge of abortion services is also limited, and we know that the fertility rate among the adolescents is also high, and around 14% of contribution to maternal and mortality comes from the women below 20 years. So this is the main issues of the adolescent health in Nepal, and we know that the nutrition status is also need to be improved. And if we talk about the adolescent health program in Nepal, we have three approaches of service delivery, that is the school, community, and health facilities through the different following programs, which are the adolescent-friendly services, health facilities, adolescent-friendly information corners, comprehensive sexuality education, national school health and nutrition programs, and adolescents are distributed to iron folic supplementations. These are the major programs of the adolescent health programs of the Nepal. So these are the background of the context of Nepal. So I want to share that Nepal has endorsed the adolescent health related strategy in 2002, which was the early country in the South Asia. And we have established around 1,337 centers of adolescent friendly by 2019, and among them 73 has made the quality benchmark and also certified as adolescent friendly services. However, the anecdotal evidences indicated that these adolescent friendly remains inaccessible to many vulnerable young peoples. So we have a very limited evidence available on the quality of adolescent friendly services, so that we studied this, the team has studied with the objective of to assist the service readiness of adolescent-friendly services sites, to explore the service providers, health facility in charge, and other key stakeholder perspectives about the opportunity and challenges of adolescent-friendly services, and to assess the perceived quality of both from the side of adolescent and from the side of service providers, and to recommend the ways and approaches to improve the access to quality adolescent-friendly services and their utilizations. That was the study objective, and this study was done throughout the country with the 14 purposefully selected districts, which represent 2 districts from each provinces. And the methodology, it is does cross-sectional mixed method, both qualitative and quantitative, and study population and sample size 320 adolescent, 82 health facilities, and 54 stakeholder was our study populations and sample size. And we use health facility readiness checklist, client exit interview, in-depth interview guide for the stakeholder as a study tools. And data collection was done through the survey, and qualitative, quantitative, descriptive analysis, and coded emerging themes and content analysis was done for the data analysis, and ethical consideration was also taken from the NHRC, Nepal Health Research Council. So I want to discuss some key findings of this studies. For the study, we have assessed the service readiness throughout the country, how the adolescent-friendly services is the adolescent-friendly service sites are ready to provide the service readiness. It was found that only 58%, only 10% has a readiness, high readiness, whereas we have a 23 readiness standards, and if more than 17 standards were met, then we have identified that as a high level of readiness for the services. If we go to the hospital and primary healthcare and health facility levels, still need to improve the service readiness even in the big hospitals. And if we see the readiness in the 3 sections, that is the readiness was assessed into the in terms of the physical infrastructure, even youth engagement, and the availability of contraceptive and drug availability, contraceptive and other drugs. The data shows that when that study shows that youth engagement, we have a mandate to include the adolescents in health facility operational health facility operation and management committee, but very limited youth were engaged for the health that committees. So youth engagement was also low, and contraceptive availability and physical availability, physical facilities, that means infrastructure, these all things need to be improved, it was seen. And from the client perspective also the quality was assessed. And so client, most of the client, very limited client, that means 15% has perceived that the service is very good. And most of the client as is okay, okay means is also not a very good, but they are saying the okay. And so we can conclude the client perceived barriers was identified as a privacy is the main issue, family support, expression of the problem, information about, even they don't have information about the adolescent friendly services, provider responsiveness, and gender friendly providers are the main issues from the or main barriers which the client has perceived to access the adolescent friendly services. So some of the clients from the some of the client was mentions that when we go to buy ticket, we have to line up in the place for all kind of services. People usually know each other in the community, from they are from same community, and we are afraid because they may know that we are come from for what services. That was the client perspectives. So client has given some suggestion to improve the adolescent friendly services, which are the awareness activities in school and community should be increased, adequate privacy should be ensured in the health facilities, and the service providers should be the gender friendly counselors, and skill and attitude of even health workers should be strengthened, family support, community support, and RS availability of RS commodities should be strengthened. That was the main suggestions from the adolescent friendly services, for the adolescent friendly services. This is from the client perspectives. And we have also assessed the provider's perspective for the adolescent friendly services. The most of the, that means around 25% of providers reported that they felt uneasy to provide the sexual and reproductive health for the adolescents. So the main reason is they feel uneasy to provide the services where due to privacy, even the health facility has not privacy in service room side, so that they feel very uneasy to provide the services to the adolescents. Adolescents also do not tell their problem openly. Adolescents are not so open to share their services, they found it. And the adolescents' hesitations because of opposites. So from the client perspectives as well as the provider's perspectives, that is the share the same kind of barriers, that they have hesitations. Gender friendly service providers are not there. These are the issues identified during these studies. And we have also identified some stakeholders, that means health facility in charge, health facility operation and management committees also faced the problem faced by the adolescents was no proper knowledge about the risk behavior, and cannot talk openly about SRS problems. Adolescent cannot talk openly about SRS problems. So we in the community we have early marriage and no access to information to adolescent for the SRS. Sexual violence is also very common in the most of the communities. So I would like to share one of our stakeholder, who is the health coordinator from the Pattaya districts. He told that mainly female adolescents are facing problems during the menstruation period due to lack of rest, lack of sanitation, lack of nutrition food in the community, who believe in traditions and cultures have a superstitions. So this is some of the stakeholder perspectives that was found in these studies. And I would like to share some conclusive points that availability and readiness and the quality of adolescent friendly service widely varied across the facilities. I have already shown it is different from the higher health facilities too. Primary health care center and health levels, and inadequacy of meaningful engagement of adolescent in program was a major concerns That was the main conclusion from these studies. Reason such as poor health facility, that means in the readiness of the services due to the poor health facilities, low availability of commodities, inadequate guideline and protocols, and low level of community awareness are cited for the low level of readiness and utilization for adolescent friendly health services. So 6 out of 10 perceive the quality of service either very good or good. So 25% provider failed. Providers, from the provider perspective also, they feel the very uneasy to provide the services to adolescent, and early marriage is the main issues, and very reluctance to talk about the SRS problems. Inadequate knowledge on the risk behavior among the adolescents were the major problem faced by the adolescent in the community. So knowledge contribution from this study, establish new adolescent-friendly services sites and strengthen the existing facilities on the basis of quality standards set for the improvement of adolescent sexual reproductive health is the main recommendations. And strengthen the linkage. We need to strengthen the linkage among the health facilities, school, community to increase the awareness and improve their service utilizations. Basic refresher training on adolescent-friendly health services to service providers and other staffs, especially the communication skills to deal adolescents should be improved, and for them need to be time to time and refresher training for their skill improvement. Whole site orientation, because whole site orientation and sensitization is highly recommended, because only providers should not provide the adolescent friendly service. Even gatekeepers should enable them to enter to the services, so that whole site approach is recommended, and meaningful engagement of adolescents in the health facility operation management and programs should be encouraged to design. There is encouraged to include them in the designing and implementation process is the recommendation from this studies. And that is my overall presentation, and thank you for your patience. Thank you.
Thank you again. That was perfect timing. Could you put up the QR code again? Yeah. So for those that join late, our next presenter will be speaking in French. And if you haven't already done so, you just need to use this QR code and then select English if you'd like it to be translated from French into English. And then listen either with headphones or putting your phone next to your ear. So I'll just give a second if anyone else needs to do that. Okay, I'm going to introduce our esteemed next speaker, and she is Dr. Nadege Melanie. I hope I got that right. And she is from Benin, but she will be representing or speaking about her work with high-risk adolescents in Burkina Faso. And she is joining us here today from, okay, so I think that's just what happens. We need to make sure the volume's down. It'll be echoey, but that's okay. It was a good illustration. She represents the Spanish World Doctors, or the Spanish Medicine de la Mode, and we're really thrilled to have her. So please come on up.
My language, I will be speaking in French. Bonjour tout le monde.
Good morning, everyone. My name is Nadege Malène, and I am in charge of the medical coordination in Médecins du Monde Espagne. We are in charge of different chapters, and this morning I will share with you our results and findings on one project that we applied in Burkina Faso on the embedment of on the barriers to contraceptives, and I would like to share our projects related to the improvement of the access to quality FP services among vulnerable adolescents and youth, especially among youth living in the streets and sex workers in rural and peri-urban areas of Burkina Faso. The project, I would like to start with the context in Burkina Faso. We have approximately 19% of the population representing youth between 15 and 24 years old. They are our target population for our project, and the services of FP has a prevalence of 23%, and we are focusing mostly on youth in schools. Those from out of schools are unfortunately left behind, and in Burkina Faso, half of the youth do not benefit systematically from the services of family planning. Among youth not attending schools, they are mostly girls, and the exposition to early sexual relation. We can say that it starts at 17 years old, and 72% of the population represents these girls who have early sexual relations in the zone of the project. This percentage was approximately 20%. As methodology in the application of this project, we worked on two phases. One phase from 2016 to 2017, and second phase 2019-2021. We have been able to focus on 12 health centers, and we worked with 20 schools in partnerships with the local associations to be able to touch communities and to touch more youth frequenting schools. 2,695 youth, vulnerable youth between 12 and 18 years, 20. At the school level, we could touch approximately 27,000 youth identified as a youth at high risk due to economical situations. And for social and cultural reasons. We worked at a health level to reinforce the capacities of 256 health agents and social agents and teachers. And with this data that we collected, we could improve the capacity and the accessibility of the FP services. What have been access of intervention? We worked through different information campaigns on FP services, and we also worked on technical platforms in health centers. We also reinforced health agents' capacities in order to be able to offer better services to vulnerable population among youth. And our actions also focused on youth in schools by implementing different programs like developing the services and the competences of peer educators. We also made advocacy in order to achieve an exhaustive, a complete educational training for the education of youth on sexual health. In terms of key results, but while working among these vulnerable groups, we have been able to reach more than 27,000 youth, and we have we worked also. We could reach this youth with 82 workers, and they work day and night to be able to touch these vulnerable groups. And we worked with 20 teachers, 38 peer educators, with 10 established schools, and 97 health agents worked in this program. And we also elaborated on a guide to foresee the integration of the complete sexual education within the schools. And we did this with 97 agents. Those agents have been engaged to manage also to manage different ways to teach youth about different transmissible illnesses. So we can say that 12 health centers have been prepared, and confidentiality spaces have been put in place in these health centers in order to be able to ensure good welcoming within the centers, and also out of the working hours, in order to really put to focus on this group, and to develop the family planning program. We were able to identify 3 modern methods very common in these zones, and as pills, UID injection, that have been offered to youth as methods of contraception. Parents' associations have been engaged in 10 schools in order to develop and to ameliorate communication between parents and youth. We can say that we have been able to develop the services of FP at 39%. In the middle of the project, within our project, we have encountered some challenges, and we have to adapt ourselves to different challenges, as the diminution of the use of health centers by the population because they were afraid to get COVID-19, and also we worked on youth living in the streets, and but unfortunately, we had to eliminate this youth, but we could also elaborate another phase to be able to cover them. And health authorities and education authorities engage themselves to apply the recommendations elaborated within this project, and in order to really apply a complete sexual education in schools. And we have also been able to benefit financially from Affaires Mondiales Canada to be able to develop this approach. And thank you for your attention.
Wonderful, thank you. The translation, I think, worked well. It worked well for me, hopefully the same for all of you. Our third and final speaker today is Maniza Habib, and she is joining us from the Population Institute in Washington, D.C., and she is a research fellow. And as I mentioned, she's going to broaden the stage to look at this issue globally. So I think it'll be an interesting complement. So please welcome.
Thank you so much for that introduction, Jennifer. Just to reiterate, my name is Maniza Habib. I use she, her pronouns, and I'm a research fellow at Population Institute, which is a nonprofit located in Washington, D.C. And here we really focus on creating advocacy and research briefs related to sexual health and reproductive right activities. Before I dive into my presentation, I just want to acknowledge my co-presenters today and really recognize their efforts in addressing barriers to family planning within their own country context. And what I'm going to do today is kind of broaden that scope, as Jennifer said, and look at the barriers from a global perspective. It's incredibly important that we identify these barriers to be able to produce evidence-based solutions and to promote collaboration across different country contexts. We want to look at other barriers in other countries around us to understand how can we adapt what they're doing to help us? How can we help each other? I also want to note that this brief was created for individuals who don't necessarily work with family planning on a day-to-day basis, but perhaps in family planning adjacent fields to understand these barriers to be able to fully advocate for whatever issues they're concerned about, like, for example, climate change. So without further ado, I'll get started. Just to give you a quick presentation overview, I'll start with defining the unmet need for family planning. We'll watch a quick, hopefully fun animation about barriers to family planning that we've identified. I'll go a little bit into some examples that are in our brief. We'll talk a little bit about why it's important to magnify adolescence in this conversation, and then we'll comment on our universal challenges. So first, we'll identify the unmet need. So as I'm sure we all agree at the International Conference for Family Planning is an essential service and basic human right. This is a cornerstone of gender equality, and it is critical for the health and well-being of individuals, families, and communities. And yet barriers prevent individuals from accessing the family planning care that they deserve and need. Globally, many individuals and couples want to postpone or avoid pregnancy. But out of the 923 million women of reproductive age in low and middle income countries who want to avoid pregnancy, 218 million have an unmet need for modern contraception. So what this means is that they want to avoid pregnancy, but they are not using a method of modern contraception. So in the next slide, we'll watch a quick video defining family planning and outlining some of the barriers that exist across the globe. I don't know if the sound, is there sound on the video? I'll just go back a slide and back forward. I don't think it's on yet, but we'll wait. Just building anticipation for it. Exactly. Sorry? Yeah, go for it. Go for it.
That's a panel without a little
Of
IT.
course. It's part of the culture.
It's kind of nice to not have to worry about it yourself. Somebody help.
No, there it is. There it is. There should be. But it's okay. We can just keep going. Yeah. No worries. Yeah. We'll just keep going, but we can watch it in the background. There's a lot of words in it that I can just read out loud, but there are health system barriers. This can include long distances to not being stockouts in health facilities. So that's kind of what this is representing here. There's educational barriers where people have a tough time discerning between myth and fact about contraceptive methods. Social barriers can include gender inequality or stigma from healthcare providers or just general society. And legal barriers can include abortion restrictions or age restrictions or any other policies that restrict access to family planning. And we also want to note that COVID-19 made a big disruption in all of these and stopped a lot of ways that people can access family planning. And by identifying these different barriers, we can begin to think of evidence-based solutions and help to prioritize family planning in all health facilities and improve comprehensive sexual education and reduce bias in health facilities, and also advocate for policies that would help increase access to family planning. And when we do this, we can advance equality, increase education, decrease maternal mortality, prevent STIs, and reduce unplanned pregnancy. So this is essentially what we're getting at with this quick animation. It boils down a lot of big concepts into this quick thing that people can view. So essentially what we're saying here is that physical, educational, social, and legal barriers prevent millions of people globally from accessing the quality family planning services every year. And by identifying these barriers, effective evidence-based solutions can be implemented to ensure that everyone, everywhere has access to person-centered family planning services. So as you saw in the video, we've split these barriers into 4 main categories: health system barriers, educational barriers, social barriers, and legal and policy barriers. So health system barriers involve any kind of barriers related to the quality, cost, and access to health care. And examples of this include a lack of healthcare facilities, limited provider supply, and commodity supply chain shortages. So long distances to healthcare facilities restricts individuals from accessing the family planning care that they need, and this can occur anywhere in the United States, to Nepal, to Zambia. So a specific study in Zambia observed that when long and tough travel causes women to be late to their appointments, they are much less likely to ever go back. Access issues also persist in the global north. In the United States, for example, providers in rural areas report much lower numbers of offering any type of family planning, which causes individuals to travel far distances, often on unreliable transportation over different days. And finally, a lack of any supplies and stockouts of contraceptive supplies restricts choice of family planning in communities. In Senegal, for example, stockouts are attributed to a lot of the low prevalence rates of contraceptive use. So a lack of financial resources, as well as insufficient communication and training, severely impacts healthcare, leading to a need to strengthen local and national health systems. So based on this, an evidence-based solution, as I just mentioned, was strengthening of local and national health systems. So we need a combined effort of functional community health systems, a community desire to prioritize reproductive rights, and a promotion of knowledge of contraceptive services to ensure a successful delivery of family planning services. By ensuring that clinics are well-rounded in their service offerings, including couples counseling, availability of a robust mix of contraception, STI testing, regular checkups, and sexual health, then only individuals can begin to receive the care they need from one facility without having to travel long distances. In addition, effective collaboration across different institutions is required to prevent stockouts by coordinating supply chain management with demand projections and real-time availability of commodities. So educational barriers include false narratives that are taught and learned by both individuals seeking family planning care and providers providing family planning care. So this can include both myths and misconceptions about family planning, as well as a lack of provider training and providing all types of contraception. In a study from Ghana, for example, participants reported misconceptions about long-term impacts from modern contraceptive methods, including development of fibroids, infertility, birth complications, and premature death. A different study conducted among healthcare providers in Malawi found that providers lack training and expertise to carry out tasks such as the insertion and removal of IUDs, which really limits individuals' choices when they reach the clinic. Limited budgets for staff training and training modules lead to poor quality of care and gaps of knowledge among the healthcare workers. So what this indicates is, well, at least one solution is a need to increase access to comprehensive sexual education, which is a curriculum-based process of teaching and learning about the cognitive, emotional, physical, and social aspects of sexuality. Implementing this kind of curriculum over something like abstinence-only sex education or a lack of any sex education can inspire active community dialogue and to help overcome the stigma attached to family planning. And we heard in Dr. Nadej's presentation about the use of peer educators and comprehensive sexual education. So we already have an example of how this is being implemented. And social barriers refer to stigma enforced by social norms and biases. And this can encapsulate social stigma, gender inequality, or provider bias. So social stigma surrounding family planning can be sustained by cultural norms and religious beliefs. For example, a study in Senegal found that adolescents overwhelmingly disapprove of contraception and are too embarrassed to seek care, which negatively impacts their overall health and well-being, which kind of relates back to Kavita's presentation about how adolescents were not really willing to seek out family planning resources. So in addition, imbalanced power dynamics and gender norms within heterosexual relationships can leave women with little to no decision-making ability about family planning. A 2020 study of 57 countries revealed that nearly 1 in 10 women are not able to make their own choices about contraception, and this can be from a fear of judgment or even violence from one's partner, which influences a woman's decision regarding family planning. And finally, stigma is even alive and well in our healthcare facilities. Provider bias against specific demographics and methods of contraception influence the use of family planning services. Specifically, young single women face additional obstacles when attempting to receive care in family planning offices. So one study in Malawi found that more than 2/5 of providers say that they would not be comfortable providing services to young unmarried women without children. It's also worth noting that members of the LGBTQ+ community and Black, Indigenous, and people of color, as well as immigrants, experience additional obstacles when attempting to reach family planning care. So a solution to this can be increasing male involvement in family planning. There are different ways that this can be done, but entertainment education has been influential in inspiring conversations between couples about family planning. For example, in Sierra Leone, listeners to a radio serial drama about family planning were found to be 3.7 times more likely than non-listeners to say that they talk to their spouse or partner frequently about family planning. And finally, as the name suggests, the last barrier category that we'll be discussing is legal and policy barriers, which just relate back to policies that restrict access to family planning. So this can include things like third-party consent laws, age restrictions, and restrictive abortion policy. Third-party consent laws include any kind of law that requires a third party, which is often a spouse or just any other relative, to provide consent before a person can receive family planning methods. For example, in certain parts of Kenya, providers are required to have permission from a third party before accessing certain types of contraception. Age restrictions and parental notification laws on contraception also act as a barrier against family planning use, specifically for adolescents. In Indonesia, for example, family planning is strictly regulated for those who are married, when adolescents that may be in need of family planning may not be married, and there are still high rates of sexually active adolescents that are not married. And finally, restrictive abortion policy is a major barrier to family planning across the globe. Restrictive U.S. policy, for example, such as the global gag rule, prohibits foreign non-governmental organizations from receiving U.S. global funding for family planning assistance, from performing or promoting legal abortion services, even if the host countries has laws that permit abortion. And this causes NGOs to decide between accepting the necessary funds to continue their work in family planning or refuse the funding. Although this is much easier said than done, these policies indicate a need for attention from our policymakers. Political support can influence community support and increase avenues of funding for family planning. So we need both the politicians to recognize the importance of family planning to help grassroots organizations do the work that they need. And finally, consistently throughout the investigation of challenges of family planning barriers across the globe, we found that adolescent women face the toughest and tallest barriers. Many of the same barriers to access burden single women or single girls at much higher rates than other groups, and including Black, Indigenous, people of color, and LGBTQ plus members. So I just want you all to take a minute and think about different barriers that you are approaching in your work every day and how this might relate back to another country. You've noticed that I mentioned a lot of different examples throughout my presentation from different countries. And like, how can that relate to what you're doing? How does your work relate back to the direct barriers that you're thinking about? So what we did with this is essentially show how a variety of barriers work in tandem to restrict access to family planning for adolescents and youth and other systemically marginalized individuals around the world. Comparing barriers with a wide lens strengthens the argument for increasing access to family planning and helps to reduce maternal and infant mortality and unsafe abortions worldwide. And this also relates to a need to increase proper sexual health education to prevent sexually transmitted diseases and unintended pregnancies. So essentially allowing families to make the decisions, make educated decisions about family planning is a human right, and it is important for the achievement of sustainable development. So at Population Institute, along with this brief and the video, we also created like an interactive map to go over different barriers across the countries of the world. So I welcome you all to explore it, to learn about the challenges across the world, and you can do that by scanning this code right here. This is amazing technology, so you can see it, and then you can watch the video with sound, which is great. But yeah, thank you all for listening to my presentation today. I want to thank my co-presenters once more for providing us with some specifics about what I talked about today. A quick shout out to our moderator for her amazing moderation, and of course to my supervisor, I called you Dr. Bridget Kelly, Director of Research of Sexual and Reproductive Health and Rights, whom without this would just not exist, for all her mentorship and contributions. So thank you.
Thank you. Oh, this one isn't on. Get that. So we have about 15 or 20 minutes for questions. And if you'll notice behind the camera, there's a microphone, and that's helpful for translators to be able to hear, and obviously for the room to hear. So I have some questions, but if any of you have questions, if you wouldn't mind stepping up to the microphone to ask them. No, I'll start. I just, for all of all of our panelists, I just wondered if there was something that struck you in your research that surprised you the most when you started this research project, in terms of what you didn't expect to find and you found. If you have a question, if you have a response to that, obviously if you don't, it's fine, but a general question. I think the table mics are on. Yeah.
Oh, okay. I can, this is for everyone, yeah? I can start.
Yeah.
But I think just the layers and layers of barriers that exist to access something that is just a human right is just always going to be a shocking thing to look through and compile. These are just some of the barriers. These are just 4 categories, but we can keep adding to this list. I think most specifically is healthcare provider bias that is always shocking to read about, and there are different forms of it. Like in the United States, we hear a lot about provider bias in only prescribing long-acting contraceptive methods for Black people and of Latino people because of provider bias. And then you'll hear about adolescent provider bias in other countries that are sustained by cultural norms to not want to talk about contraceptive methods at all because you think that will influence them not to have sex when we know that's not true. So I think just like looking into that of someone who is so educated and like their job is to provide family planning is always going to be a shocking thing to investigate.
Yeah, thank you. Does anyone else want to respond? Yep. No, it's fine. Any other? Oh, here's somebody.
Merci, je vais m'exprimer en français.
I'm sorry, I will speak in French. I'm from DRC. I would like to ask my question to lady who talked about the project in Burkina Faso. It is a very interesting project and very similar to a project that we are doing right now in Kinshasa. We have almost the same target groups among adolescents with the similar approaches in schools, and we are also focusing youth that are not going to schools. I don't know if I well understood, but your method, you are working. You are working day and night, right? And I would like to know for when you during the night, because these youth, these adolescents are living with their parents. Can they go to health centers during night? Do they encounter obstacles? You talked about injection, DIU, and pills. DIU is not accepted at all. The EUD is not accepted at all in our regions. I would like to listen to your experience. I would like to know how you made accepted this intrauterine device in your country. Thank you.
There or from here?
I would like to thank you for your interest, first of all. To answer to your first question, this is true. When I said work that we work day and night, yes, working at night it is always difficult because we must take into account the period, the length of this community. And in fact, what we did actually, we tried to organize interviews with them in order to better reach them and to be able to share with them and to raise awareness. The night approach is more focused on organization of specific target groups. To avoid, of course, the night travels. Let's say this was our approach during our night for our night shifts. For your second question, yes, for the intrauterine device, it was a more difficult approach. This method is vulgarized and this solution is proposed to our target group, but in terms of a number of people adopting this method, there is always a restriction, or this method is usually less used and less accepted. But we still have youth who are interested with this method, with also the approach. And the information given by the health agents, of course, health workers.
Wonderful, thank you. I'm just listening to the end of the translation. Any other, oh, I see a question, if you could come up. Either one.
Hi, my name is Saad. I work for Rutgers in the Netherlands. I have a question for any of the panelists who can answer is that, Maniza, you talked about that young adolescent girls are the biggest risk category when it comes to unmet need. I wanted to ask, when you talk about social barriers, does that also include parents as barriers to contraceptive use amongst young girls? If yes, do you have any evidence or any effective interventions where parent-adolescent communication is being addressed to increase contraceptive use amongst young adolescents, especially girls? Thank you.
I think you bring up a very good point. Parents do contribute to the social stigma around accessing family planning care. We touch on it a little bit, just commenting on cultural norms and religious norms that sustain those social norms. But this is also a very entry-level brief. It's a beginning of an investigation into these barriers, and it's our interactive map is like a working map. So that's definitely something to investigate further. But yeah, definitely check out our map and see if it's on there too. But I think you bring up a good point. Parental bias does impact individuals from accessing family planning like, across the globe.
I have a question that kind of builds on that, if you don't mind, which is, I'm curious, who is your target audience, or who is most using the maps and videos? Is it policymakers? You mentioned that they're kind of simplifying data, so I was curious who was most interested, and also wondered if you're adapting other data to make animations like the one you showed us.
Yeah, that's a great question. So, like I stated, the brief is mainly for individuals who aren't working closely with family planning. So, we have so much great research out there about barriers to family planning that across the globe, but it's hard to translate into advocacy, especially if it's not something you work with every day. So the purpose of this, like policymakers or those who are working climate change or other related fields can take a look at this and understand what exactly is preventing people from reaching family planning and what can be done about it from their end.
Here's the question. Thank you.
Je vais m'exprimer en français. Donc,
I will speak in French. Please do use the interpretation. Yes, I do like. I am Julian. I am coming from the Burkina Faso, and I really liked the approach used to reach a layer that is most of the time forgotten. This youth that are not frequenting schools, youth that are living in the streets, or prostitutes, sex workers. So, for the other countries, what are really the barriers, and do you take into account this category? Because most of the time, this category is forgotten, and most of the time, we are working with youth going to schools, but we do tend to forget youth living in the streets and sex workers. Thank you.
Well, I thought it was direct. Okay. Sorry, the translation didn't work right away, so I didn't hear that. So, are you ready to answer?
Okay, thank you. Thank you for the question. Sorry, but we couldn't catch you So in the Nepal, in the context of Nepal, we have three mechanism of service delivery to address them. The school is not working for them because they are out of school. So we have a community approach and the health facility approach, and that means that we have a community volunteers, community health volunteers who has work in the community levels, and they have a network with the mothers groups. So that means the mothers group also included some adolescents girls. That means the mothers groups, and in that mothers groups, adolescents are also welcome to come there and discuss their issues. So different issues are discussed on that mothers group. So out of schools, adolescents can come in that groups, and even though we have a some of the networks who work like a peer-to-peer educations for those people, girls who are not going to schools. Such kind of projects are also going on. So they address. But we wish to that most of that means all girls should come to the schools. That is the national priorities. But still we have a some schools are out of some girls are out of schools, so they are addressed through that community approaches. Thank you.
And I have a follow-up for you as well, which is in your presentation, when you looked at the evaluation, some of the concerns were about the quality benchmarks, like the youth were not engaging in the committees, and confidentiality, not highly rating the quality of care they received. And I just wondered how you're prioritizing remedying some of these findings, and if you have support within the government to fix some of these problems, and which ones you're focused on.
Thank you. To address these issues, we have initiated that to include the adolescent and youth in groups, to include in our most of the committees, some of the meetings where we used to plan and design the programs of adolescents. And we have recently endorsed the adolescent health guidelines that already included that guidelines direct to the all national and sub-national level to include the adolescents in their committees and discuss with them to include their priorities and their priorities for the qualities. So I have also mentioned in my presentation that there was a SFOMC, that means Health Facility Operation Management Committee. That committee look after the health facilities. So there is a mandatory to include that adolescents on that committees. So that
it sounds like there's a plan. That's
yes.
good. I'm just going to do a last call for questions, and I know the next activity is the closing ceremony, so we could take the opportunity to end and get our seats at that. I also wanted to mention that there's an evaluation, I think, of the sessions and as well as ICFP in general that will come to everybody that's registered, so encouraging you to fill that out. And also on the website, eventually, as I mentioned at the beginning, I believe the papers and presentations will all be available for those that want to learn more. So I think, not seeing any other questions, I'd like to close this session and offer the opportunity to thank all of our wonderful speakers today. Thank you, and enjoy the closing ceremony.